and we have described the various theories of causation, that is the concepts of disease. So once there is health, there is disease, we have to control it, right? That is the automatic conclusion. So today we are going to end this chapter, a very, very important chapter from which long questions and short notes may come. And therefore, I have been going a little slow. This is the base, this one and the next one, that is epidemiology. So we will talk about concepts of control. This can come as a question as such, but you've got to note down the 5-6 points that are there in the concepts. And they are disease control, disease elimination, disease eradication, monitoring and surveillance, sentinel surveillance, and evaluation of control. Of these, elimination and eradication, you may get a question as to what is elimination and what is eradication. The difference, which is very easy. But most of you fumble because you don't attend the initial classes or you have no concept as to what we are talking. They are simple English words. And then we have 2 more English words, monitoring and surveillance. They are almost similar but different. And along with surveillance, we have another word attached with a prefix, that is sentinel surveillance. So you got to remember elimination, eradication, monitoring and surveillance, and sentinel surveillance. Am I audible? Am I audible?
Yes, sir.
Yes, sir.
Why am I asking is because the electricity went out here, So disease control, it describes operations aimed at reducing incidence. We all know what is incidence by now. We all know what is duration of a disease. That in the present pandemic, there is a duration. After you get exposed to the virus, maybe you take some time to get the disease. And we described it nicely in the last class when we talked about the natural history of disease, which is again a long question in itself. It's a very, very important part that you must know. Okay, and we have effects of infections and financial burden to the community. Obviously, when we have operations aimed at reducing disease, we have financial burden. Disease agent, which persists but ceases to be a public health problem. Soon we will, I wish, God is kind, and we will have the COVID agent around us, the coronavirus, but it ceases to be a public health problem. Right now, it's a major, major public health problem. So therefore, we have the agent all around us, like malaria agent, tuberculosis agent, or leprosy agent, but they are not that much of a public health problem all over the globe. I hope you understand. And there should be a state of equilibrium between the agent, host, and environment. But all you got to know is the important slide, that is this, that when you are asked a question on concepts of control, mention these 6 points and just mention 1 or 2 lines against disease control, and then quickly come on to elimination, which is, as given in green, interruption of transmission of disease from large geographic regions, areas, or countries. Remember, it is not eradication. Polio has been eliminated from India. It has not been eradicated from the world, right? Whereas smallpox has been eradicated from the world. So therefore, there's a subtle difference. Please understand the English meaning. Interruption of transmission, that is the total stoppage of disease transmission from a large geographic area. There are certain countries, small countries, they claim, like Croatia and all that they have stopped transmission of coronavirus. So therefore, they have eliminated it. We have eliminated only a couple of diseases, like polio, guinea worm disease, whereas bigger countries more developed countries like the US and UK, they have eliminated a lot of diseases. So therefore, elimination. It is interruption of transmission, I repeat, from a certain geographic area or a certain country or a couple of countries. Eradication is total elimination from the world. Termination of all transmission of infections from the globe, from the planet. It's an absolute process. Please appreciate this. This is a very, very small thing, but it is often asked. And the biggest and the only example is eradication of smallpox. So therefore, we have 3 diseases presently which can be eliminated. One is polio, which has gone from many countries, but not from all countries, like Afghanistan, Pakistan, and perhaps one African country, Nigeria. Polio, measles, and dracunculiasis. Dracunculiasis eliminated from India. I taught you this in the chapter on community medicine, communicable diseases, but it has not been eliminated from the whole world or eradicated. Measles, that's why we are trying very hard with vaccination and all that to now eradicate measles. So somebody may ask you in the Viva, in case you are doing well, name a couple of other diseases which are liable to be eradicated. And your answer should be polio, measles, dracunculiasis. So therefore, once it is eradicated, morbidity reaches a very low or nil level. State of equilibrium is maintained between the agent, host, and environment. And therefore, we have a state of equilibrium in many diseases, but they are not eradicated. Malaria, yaws, plague, kala azar, yellow fever, we have an equilibrium kind of thing, but they are not eradicated. Now we come to two very, very important terms, which are monitoring and surveillance. Please remember that we all have a class monitor, right? Who stands and who monitors the class when we are, in the school. Right now we have a CR whom you don't bother. You don't just care about him or her. So that is not a monitor. That's why the name is CR. And this is monitoring. Performance and analysis of routine measurements aimed at detecting changes in the environment or health status of the population. Some of you may be doing this ICMR project and all that. What they do, by collecting data, they are monitoring and then they are analyzing the data. So it's a process of monitoring. It's a continuous process. Like we are monitoring air pollution, noise pollution, water quality, growth and nutrition of a child. So therefore it is, I repeat, performance, collection of data and analysis of routine measurements aimed at detecting changes in the health status or in the environment around us. You have to mug up these definitions, friends. They will be asked you in the exam, in theory, or in the Viva, and you got to just vomit them out. So therefore, remember what is monitoring. As far as surveillance is concerned, look at the green part. It is also continuous, like monitoring, but it is a continuous scrutiny of factors that determines occurrence and distribution of disease and other conditions of ill health. We can say monitoring, like I gave you the example of an ICMR project or a survey that you do, is one time. You just go and monitor the class. You just go and take some data and then jot down the data, analyze, right? Whereas if you take the data every day over a long period of time, that is what is surveillance. Surveillance, CCTV surveillance, continuous. It is not monitoring. It is not just one click and then the camera switches off. CCTV is continuous. That's why the word is surveillance. Please remember, surveillance is continuous scrutiny of factors that determine occurrence and distribution of disease and other conditions of ill health. You got to mention or, remember both these definitions, like you have to remember the definition of health, you have to remember the definition of elimination, eradication, incidence, prevalence, all these things we have already covered. And they are pet, definitions which are asked in the Bible. So difference between monitoring and surveillance is monitoring is one specific and essential part of the broader concept of surveillance. I told you, we go to the class, take some, data, we are monitoring. But if you take that data all day, perhaps over the week or over 1 year or 1 month, that is surveillance. Surveillance is more continuous and it is ongoing. I hope you appreciate the difference. Don't look at the dictionary meaning because as far as dictionary is concerned, they are synonyms. Now, we have something called as sentinel surveillance. I hope all of you know what is sentinel. Sentinel is somebody who stands at the door. He is the person who will allow you inside or not allow you inside. He is the person who stops the enemy. He is the guard. It's a method of identifying the missing cases and thereby supplementing the notified cases. But then sentinel surveillance is not guarding. It is identifying the missing cases. In spite of strong surveillance system in India, in spite of strong surveillance system in our state, we still miss some cases of COVID. Okay, we are trying to find those missing cases by sentinel surveillance. That's why missing is an apostrophe, missing is in inverted commas. Please remember, a method of identifying the missing cases and thereby supplementing the cases that you already have. All this is data collection. estimate the disease prevalence by extrapolating data to the entire population to estimate the prevalence. Actually, when we have the actual number of cases happening in say about 20,000 people all around us, we can magnify the data, multiply it by the population of the state or India, and find out the actual prevalence. Okay, we can't we can't take data from all the people in the state. So what we do is we do some small studies. We do studies here, there, in some village, in some city, and then we extrapolate the data. All these things you will learn as you become from MBBS to MD. When you do a research yourself, you will learn these words a little more. So what are the advantages of sentinel surveillance? The reporting biases are minimized. We have some reporting biases. We have some people who are reporting certain number of cases, but they will say, since I'm reporting 20 cases, I shouldn't be reporting just 5, because they will think I am not trying to do my duty well. 25 cases of COVID in my area. It's a bad name. I should only report about 20. So those biases are minimized because there are other sources which will intimate those cases. Feedback of information to the providers is simplified. We have many sources, including medical colleges, which are now supplying data to the state authorities. So therefore, we have medical colleges, state government hospitals, private practitioners, and individuals who are reporting. And we have a proper number of cases with us. We are not fudging the data, as they say. Telangana or Maharashtra, they are fudging data. We read in the news or we hear in the news. So therefore, this kind of fudging data is avoided. The missing cases are identified by a method called as sentinel surveillance. Competent physicians, institutions are involved to report diseases. They can provide more valuable and detailed information than traditional notification system. Notification, I am sitting in my room, 10 people are coming, 5 are the cases. I notify them, by filling up some forms or writing to the authorities. But then there are 50 more cases outside who are not coming to me. How do they get notified? By sentinel surveillance, by another responsible physician or some institution which has identified them. Sentinel sites should be developed into a notification system, which could be less costly than developing and maintaining an ongoing notification system. Sentinel surveillance is the answer to a proper notification system. In case there is a short note, just define it. Define it by saying it's a method of identifying the missing cases and thereby supplementing the notified cases, and then add a word that this could be developed into a good or a perfect notification system. What the advanced countries have achieved is a proper sentinel surveillance. In our country, because of huge population, because of lack of infrastructure, lack of healthcare workers, because of lack of a commitment to work, we have a very lax notification system. So in case we have 1 million TB cases, we are actually reporting 50 lakhs. I hope you are getting me. Evaluation of control, well, we evaluate everything in life. Once you are appearing for a test, we give you marks, evaluation. A process by which results are compared with intended objectives. When you do a study, you have certain objectives in mind. I want to study this. Okay, and you collect data and you analyze data and you come to a result. That result is your assessment result. Like when you give an exam, results are out. So that is an assessment. Whatever control measures are there, we should be assessing. So I again come back to the first slide, which is most important, that you must remember these 6 headings: control, elimination, eradication, monitoring, surveillance, sentinel surveillance, and evaluation of control, in case there's a question called, what are the concepts of control? I keep repeating these things, bad habit from my side, but it is to inject in you that these are the questions which come, and you people just even don't write the proper headings for us to proceed. We come to a very, very important part of this chapter, a very, very important part of your, preventive and social medicine curriculum, which is prevention. Because the very word SPM contains prevention, social and preventive medicine, preventive and social medicine. Now, we all know the goal of medicine, I am repeating this, is to promote health, preserve health, restore and minimize suffering. Successful prevention, we all know, we have done all this before this, I'm just revising. We have to know the causation. There are 6 theories of causation: germ theory, epidemiological triad, okay, triangle of epidemiology, web of causation, advanced triangle of epidemiology, advanced model. Then we have multifactorial causation. Finally, we describe the natural history of disease. Please remember these things. I repeat them because I feel very sad when you can't write them in the exam. I try and shout, I try and emphasize, I try and repeat for you to know what is important. So, therefore, for successful prevention, we should have the cause in mind. We should know the risk factors. Risk factors is a short note. I taught it to you in the last class. We must know what's the risk factor, what's the risk group. And then I talked about early detection and treatment, which we will again repeat now. We will have some national public health programs, which are like National AIDS Control Program, National Vector-Borne Disease Control Program, and all these things which have been taught to you simultaneously in the chapter on communicable diseases, and some in the chapter on non-communicable, which HOD madam has taken. And like for any successful control or prevention program, we have to have a continuous evaluation process. Please remember the basics. Levels of prevention: 4. Primordial, primary, secondary, tertiary. Nothing great. You will be asked what are the levels of prevention in the viva and in the exam. Now this diagram is familiar to you. This we talked about in the previous class. Pre-pathogenesis and pathogenesis. I told you how the epidemiological triad, they are all important for causing the disease in the human host or entering the human host. After entering the human host, they can go to various steps, ultimately cause death, or on the other hand of the spectrum, they can cause recovery. Okay? But if you look down in the diagram, you will find that levels of prevention are marked as per the stages of pre and pathogenesis. Okay? In case you apply some methods in the pre-pathogenesis phase, that is primary prevention. Whereas in the pathogenesis phase, once you have signs and symptoms, if you apply some prevention here, that is secondary prevention. Whereas once the disease progresses to disability and defect, the only thing that you can do is tertiary prevention. Now you will ask me, where is primordial? Primordial is even before this, okay? It is even before the disease process starts. Appreciate this diagram. Look at it carefully. Once you finish, listening to me, go back, open your book and look at the diagram properly. Some of you reproduce the diagram in toto in the exam and full marks to them when the question comes on natural history or levels of prevention. Primordial prevention. I'll give you an example. From your childhood, your parents teach you, wash your hands, wash your feet when you come back from outside. In the morning, the first thing that you do is get up and brush your teeth. Before you touch any food item, wash your hands. When you go to somebody else's house, leave the slippers outside or leave the shoes outside. Okay, so these are various methods of primordial prevention. Now, what is it? It is prevention of emergence or development of risk factors in countries or population groups in which they have not yet appeared. Don't worry about the complicated English. Just try and understand. I think that something is going to happen to you in 10 years' time, and I tell you to take care from today. I really don't know whether somebody is going to be obese after 10 years. Even you don't know. But you are going to take care from today. You're going to have a good lifestyle, healthy lifestyle. You're going to go for exercises. You're going to go for jogging. You're going to eat a proper diet. You're going to avoid the addictions like smoking and alcohol. So therefore, you are preventing certain risk factors. You are preventing the emergence of risk factors in you. I never smoke. I don't drink. Therefore, there are no risk factors in me. That is because I have prevented them from my childhood, from my teenage. Okay? So, remember, primordial prevention is prevention of emergence or development of risk factors in population groups in which they have not yet appeared. So you assume, you think it may appear, and therefore you stop it by speculating. What are the examples I've just given you? And the mainstays of such primordial prevention are individual and mass education. We have been taught by our parents, our grandparents. Sometimes we listen to the news or we see things on TV or we read it in the newspapers, and therefore we are educated, or we see something on our phone, some kind of message. So therefore we are educated and we are aware that we should not do this. Primordial prevention. Please appreciate what is primordial prevention. It is not primary prevention. Primary prevention is action taken prior to onset of disease. And therefore, I'll again go back to this diagram. Primary prevention. It is in the pre-pathogenesis phase when agent, host, and environment are present. Primordial, you cut out the agent and you develop a healthy host and also perhaps healthy environmental factors. Therefore, it comes much before pre-pathogenesis. But once you have the disease process, you will have to take primary prevention. Action taken prior to onset of disease. We know that the coronavirus is here. So therefore, what we do is we wash our hands, we wear a mask, and we maintain distance. Therefore, we are taking primary prevention prior to onset of the disease, and that removes the possibility that a disease will ever occur. It is included in the concept of positive health, and it's a holistic approach where agent, host, and environment all are controlled. It's a safe and low-cost method, and it is increasingly being identified with health education. Please remember these and elaborate once the question comes in the exam. Now, primary prevention can be of two types. There can be population strategy and high risk strategy. That is how we attack the risk factors. Okay, we try to modify the risk factors. Population strategy is for the whole population. We advertise smoking kills, alcohol is dangerous to health or something. Whereas in high risk strategy, we select some people who already have risk factors like high cholesterol, high BP, diabetes, unhealthy lifestyle, and we try and modify these factors which are already existing. So we are trying to attack two types of people here. One is the general population and one is the high risk population. By this time, you should be aware what is a risk population, what is a risk factor. Okay, we have described it in the last class. So population strategy, you don't have to read anything. It's directed at the whole population. We have to change the socioeconomic status, uplift the downtrodden. We have to tell them that you have to adopt a healthy lifestyle. Don't smoke, don't drink, go for exercises, adopt a healthy lifestyle, have a healthy diet, rest for a while, don't be stressed, don't take so much of mental stress, and all these things are lifestyle changes. So that's the population strategy. Whereas in high risk strategy, we try and take care of individuals who are at risk. I already explained this to you. People who are at risk, people who already smoke, who already drink, who are already obese, who don't have a proper diet, you separate them and you target them separately. Secondary prevention is nothing but EDPT, early diagnosis, prompt treatment. You may ask that this is a kind of treatment. Why should it come in prevention? Friends, in case you don't treat me, I may transmit the disease to you. That's how corona is spreading. Or for that matter, any other disease spreads. So now appreciate that action which halts the progress of a disease in its early or incipient stage and prevents further complications is secondary prevention, and it is nothing but early diagnosis and proper treatment. Okay, and prompt treatment. If you remember the diagram of natural history of disease, in the pathogenesis phase, secondary prevention came early. The moment the causative agent is in your body and it is manifesting, you take treatment and you stop any further progress or any further complications. That is secondary prevention. Well, there are many drawbacks. Patients have already been subjected to mental or physical anguish, loss of productivity, difficult in controlling the disease at this stage, because in spite of treatment, many COVID patients, I'm just giving you examples of COVID only, but they are succumbing. It can be expensive, treatment is very expensive, and it can be less effective. So therefore, we again remember primary prevention, which is less expensive and more effective. And finally, we come down to the last level of prevention, which is tertiary prevention. All measures available to reduce or limit impairment or disability, minimize suffering, is and promote patient's adjustment to immediate conditions is called as tertiary prevention. The disease has already progressed. Complications have happened. Disability may be there. So you got to prevent that. Many of you may be remembering the word rehabilitation. I am already addicted to drugs. I check into rehabilitation. So I am beyond repair, but they are trying to get me back to normal life as far as possible. I am not taking treatment. Treatment is not affecting me. I am beyond primary and secondary prevention. So what I am doing, I am getting rehabilitated. When disease has progressed beyond early stages, intervention in the late pathogenesis phase is required. Defect and disability are stabilized and therefore they are minimized. They are going to stay, but they are minimized. And what are the types of tertiary prevention? We have psychosocial, vocational, medical components of tertiary prevention. Well, if you have understood what are the levels of prevention, the next question that is asked to you is what are the modes of intervention? And it is almost the same. The modes of intervention and the levels of prevention are almost the same. And how? What is intervention? It's an attempt to interrupt. Two people are quarreling, two friends are quarreling. You try to come in between and say, hey, don't fight, right? So that is intervene or interrupt. So here we are, the agent, host, and environment are there, and we are trying to intervene. It's almost the same as prevention. The modes of intervention, unlike the levels of prevention, are 5. Okay? And if you now see the diagram in your book, if you just see the last part, you will find that health promotion, specific protection are under primary prevention, which was here in the last diagram. Early diagnosis and treatment is in the secondary prevention. And disability limitation and rehab comes in the tertiary prevention part. So now you know that how the levels of prevention have been again taught to us in a new mode, that is modes of intervention. It's nothing but the same levels of prevention. The first two modes of intervention are primary prevention. This third mode of intervention is the secondary prevention, and disability limitation and rehabilitation, which are the last two modes of intervention, are included in tertiary prevention. I will not repeat this, but remember this, understand this. In your exam, you cannot say this simple thing also. One thing you will appreciate is that there is no primordial prevention here. No modes of prevention caters to primordial prevention. So primordial prevention is a later concept which came in the 80s, and therefore it has been included in the levels of prevention. So they are health promotion, specific protection, early diagnosis and treatment, disability limitation, and rehabilitation. Health promotion is the process of enabling people to increase control over and to improve health. It's not if, it's off. The process of enabling people to increase control over and to improve health. Health promotion. Okay, I'm exercising daily. I go for a morning walk. I again take a healthy diet. I avoid alcohol. So therefore, I am trying to increase my immunity. And it is not directed against any particular disease that I am suffering from, but it's a general kind of a mode of prevention. Health promotion. Remember this. The well-known health promotions are health education, environmental modifications, nutritional interventions, and lifestyle and behavioral changes. I just gave you an example of lifestyle. We have to, change our diet pattern, take a balanced diet. We have to change the environment around us, make it more healthier, cleaner, hygienic, and we have to also educate the masses about the modes of intervention. Health education, we all know, we will have a separate chapter on this and they will teach you. Health education is defined as the principle by which individuals and groups of people learn to behave in a manner conducive to promotion, maintenance, or restoration of health. It is a cost-effective method. WHO's constitution says the extension to all people of the benefits of medical, psychological, and related knowledge is essential to the fullest attainment of health. Education to health, for health is to, it begins with people, and therefore there are various targets like general public, patients, priority groups, health providers, community leaders, decision makers. Environmental modifications, safe water. We are doing the chapter on environment. You are reading about safe water or potable water. Installation of sanitary latrines, you will read that a little later. Control of arthropods, insects and rodents, you would read. Improvement of housing, that is also a chapter or an aspect of the environment chapter. And improvement of interpersonal relationship, that is what is environmental modifications. We have nutritional interventions. We should have proper foods, proper diet. We should distribute food to vulnerable groups. Midday meal program, ICDS program. They give nutrition to the children and the mothers. Child feeding programs, food fortification. This you have read in nutrition chapter, and nutrition education. Lifestyle and behavioral changes. I have been repeating that. Specific protection. This is possible only in a limited number of cases. Currently available interventions are immunization. Okay, we only immunize the child, the pregnant lady. So therefore, specific protection. Chemoprophylaxis, we will talk about this in the chapter on epidemiology. It is something like I'm going to an area where there is malaria and I'm taking the drug before going to that area, thinking that if I take the drug before, malaria will not happen to me when I go to that area, which is highly malarious. So therefore, chemoprophylaxis is another form of specific protection. Protection against occupational hazards. There's a chapter on occupational disease. We will read about protection against them later on. Protection against accidents. You already covered in the chapter on non-communicable diseases. Protection from carcinogens. We have been taught about cancers and avoidance of allergens. Many of us have allergies in our life, pollen, egg yolk or something, and we avoid them. Control of specific hazards in the general environment, air pollution, noise, water pollution, control of consumer product quality and safety of foods, drugs and cosmetics. I need not explain that. We all know that there is stringent control by the drug controller, by the food controller and all this. Whatever packaged food we get, whatever raw food we get, they are all supposed to be quality checked, and then only they are supposed to be given to the consumer. Sorry. Okay, so that was health specific protection. There is a word called as health protection. Don't confuse it with health promotion. Health protection is the provision of conditions of normal mental and physical functioning of the human being individually or in a group. It's overall protection, okay? So it is not health promotion. Early diagnosis and treatment, I've already told you about it in the secondary prevention part. I will not repeat it. Early diagnosis can prevent the occurrence of further cases, secondary cases, prevent long-term disability, and prognosis will be better. Mass treatment, we have already taught you that in, say, perhaps filaria. Okay, we have taught you about the mass chemotherapy in case filaria has been covered. You must recollect that there is mass treatment for some diseases. Then we come to the fourth mode of intervention, that is disability limitation. I know we have got some disability, but we got to limit that. The objective is to prevent or halt the transition of disease process from impairment to handicap. Friends, please concentrate. Sequence of events leading to disability and handicap. Very important. First, the disease happens, then there is impairment, then there is disability, and finally we have a handicap. They are all similar words. If you see the dictionary, they are almost similar. But as far as preventive medicine or medicine is concerned, they are different. Okay? We all know that disease causes impairment. What is impairment? Loss or abnormality of psychological, physiological, anatomical structure. Example, loss of foot, fracture of a bone, defective vision, mental retardation. These are loss or abnormality of psychological, physiological, anatomical structure. Just close your eyes and imagine loss or abnormality, impairment. Okay? An impairment may be visible or not visible. It can be visible. I have a fracture or I have a loss of a foot because of diabetes. I had a amputation of a foot. Or it can be not visible. It can be inside me. Like in leprosy, nerve impairment leads to plantar ulcers. So therefore, one impairment which is inside, nerve impairment, leads to some ulcers outside. What's a disability? Because of an impairment, we get a disability. An affected person may be unable to carry out certain activities considered normal for his age and sex. Therefore, because of this loss of my arm or foot, I am not able to perform certain activities. Like because of my loss of foot, I'm not able to walk properly. So I have a disability. Therefore, impairment causes disability. A restriction or lack of ability to perform an activity in the manner or within the range considered normal for a human being. These are long definitions. You can write your own definition without mugging up from the book, provided you understand the subtle differences between impairment and disability. And finally, we have handicap. As a result of disability, the person experiences certain disadvantages in life and is not able to discharge the obligations required for him and play the role expected of him in the society. I have lost my foot, I cannot walk properly, and therefore I cannot go to certain people's houses where there is a staircase and I have to climb up to the first floor to attend a function. So I am not able to discharge the roles which are expected of me as a normal human being belonging to the society. So my handicap is I'm not able to attend the functions. A disadvantage resulting from an impairment or disability that limits or prevents the fulfillment of a role. See, I have marked those important things in blue. It's handicap doesn't allow you to perform a role. Disability doesn't allow you to perform an activity. It's a restriction or lack of ability to perform an activity. Whereas impairment is a loss or abnormality of a structure of the mind, of your mental or physical structure. Okay? So understand the differences and then you will be able to explain in the exam. Example, accident is a disease or disorder. Loss of foot due to the accident is an impairment. It can be extrinsic or it can be intrinsic. I cannot walk, so therefore I am having a disability. And since I cannot walk, I am unemployed. No employer will take me because I am not efficient enough. And therefore that's my handicap. Remember this. Disability prevention is also mentioned in the book, but please remember, disability prevention is not disability limitation. Use the words rightly or correctly in the exam. Modes of intervention are 5. I'll repeat. Modes of intervention are 5. And what are they? I'll again go back to that slide so that you people know. Health promotion, specific protection, early diagnosis and treatment, disability limitation, and rehabilitation. So remember these, and then only you will be able to write the answer. Somebody is calling me. I don't know why. And finally, we come down to rehabilitation. It's the combined and coordinated use of medical, social, educational, psychological, and vocational measures. These words have to be used in the definition. Medical, social, educational, psychological, and vocational or occupational measures for training and retraining an individual to the highest possible level of his or her functional ability. Well, I have lost my foot due to an accident. I cannot walk. I cannot be employed. But I can self-employ myself in the house, write a blog, or do something like working from home right now. And I am trying to rehabilitate by earning some money. That is my vocational rehabilitation. Mentally, I'm happy because I'm working and people are, interacting with me. So psychological rehabilitation. Socially, people come to know I make some friends. So therefore, it's a social rehabilitation. Since I'm taking treatment also, and this takes my mind off that, bugging thought of having lost a foot or that terrifying thought, and therefore I'm also getting medically rehabilitated. So rehabilitation can be of medical rehabilitation, vocational rehabilitation, social rehabilitation, and psychological rehabilitation. Restoration of function, restoration of capacity to earn the livelihood, restoration of family and social relationships, and restoration of personal dignity. It's so important that you have psychological rehabilitation. Many people consider committing suicide because they think that they are not getting psychological rehabilitation. I am not getting work. I was a famous film star and now nobody is bothered about me. I am not getting that kind of personal dignity and confidence which I used to have one time. I decide to take my life. Well, that is not the way. You have to be mentally strong, seek help, and psychologically rehabilitate yourself. What are the examples of rehabilitation? Establishing schools for the blind. We all know blind schools. Provision of aids for the crippled. There are many people, philanthropic organizations, which provide the Jaipur foot free to the people who have lost a foot. Reconstructive surgery in leprosy. Many surgeons, in spite of being not very, very rich, they are free of cost. Graded exercises in polio by the physiotherapist. We have a physiotherapist in the hospital also. Change of profession for a more suitable one. Since I was, working in an office, but now I can no longer work there. I changed my profession. Okay, so these are the various types of rehabilitation. Please remember, interventions or modes of intervention at the earlier stages are feasible. Later on, as you go towards disability limitation and rehabilitation, they become tougher. Changing pattern of diseases? Well, in this one term is very important, which is epidemiological transition. This may come as a short note or a viva question. Please remember the disease pattern is changing. When your parents were younger, when your grandfathers were younger, the disease pattern was more of communicable diseases during 1947, 1950. Whereas now, there is a gradual shift to non-communicable diseases. A characteristic shift in the disease pattern of a population as mortality falls during the demographic transition, acute infectious diseases are reduced, whereas chronic, degenerative, lifestyle diseases increase. And that is what is epidemiological transition. It was coined by a person called Umran in the 1970s. Remember this definition, coin your own definition, and write it in the exam or blurt it out in the viva when you are asked. Okay, so the changing pattern of disease is basically nothing but epidemiological transition. The world over, communicable diseases are slightly coming down, though we are a poor and underdeveloped country, and we are still having communicable diseases, but we are slowly increasing our, incidence of the non-communicable diseases. 5 more minutes. Developed countries have experienced a dramatic change, more of non-communicable now, whereas in our country, it is more of communicable still, almost 50-50, but non-communicable are taking over. The second cause is cancer, heart diseases are taking over in the US. Third cause is CVAs. I'm talking about the US. The chronic non-communicable diseases and conditions have now supplanted acute infections, and this is what is epidemiological transition. There has been a steady increase in social pathology due to alcohol and drug abuse. Again, these are lifestyle patterns. Lung cancer and other chronic lung disease due to smoking is also increasing. Obesity is occurring. So all these are non-communicable diseases, and therefore the infectious diseases are coming down. Remember this diagram, draw this diagram in the exam, or remember this when you talk in the viva. That is what is epidemiological transition. Please remember this diagram. It is not given in the book. Developing countries, I told you, like India, like Pakistan, Bangladesh, the Southeast Asian countries, we are still developing. We still have communicable diseases, diarrhea, acute respiratory infections and all that, but we are also now slowly overtaking them by the non-communicable ones. Community health, community medicine, they are all defined in the chapter. Social medicine, they are not asked in the exam, but you can just have a look. I have written them because they are there in the chapter. And community diagnosis. In case some odd examiner gives you these terms, think and answer. There's nothing great. And lastly, we come to disease classification. We all have heard about something called as International Classification of Diseases. What you talk of here, the person or the doctor in America should also understand. So therefore, there is wide variation among countries in criteria and standards adopted for diagnosis of diseases and their notification, making it difficult to compare national and international or inter-country statistics. A system was required where diseases could be grouped together with certain common characteristics that would facilitate statistical study of disease phenomena. John Grant first arranged the diseases in alphabetical order, later as per the parts of the body and all that you need not know. But international classification of diseases is the baby of the WHO. It is right now undergoing 10th revision. It has undergone the 10th revision and almost the 11th revision is ready. Every 10 years, like the census, it is revised. Okay? ICD-10 has 3 volumes. Right now, we are following the ICD-10. You need not know what is there in the volume, but you should know it's a system of classifying diseases so that internationally we have a common kind of a code. ICD-10 has 21 chapters, and ICD 9 had 17. Every ICD revision, chapters are being added. Okay, so see, these are the chapters. This is a table given in the book. You just have a look. You don't have to read in between. And if at all it comes in the exam, it has never come, it will come as a short note. Okay. Right now we have ICD 11. You must add a note on ICD 11 also in case the question is ICD. Following an alpha revision in May 2011 and a beta revision in May 2012, a stable version of ICD 11 was released in 2018. And finally, this will be implemented from 2022. Actually, it should be 20 because I told you every 10 years. But ICD 11 will officially come into being with effect from 2022. And probably initially they said there will be 26 chapters. Now they say it will be 28. And if you remember, ICD 10 had 21 chapters. We also have something called as ICF, International Classification of Functioning, Disability and Health. Only the functioning F is included. D and H are not included. Classification of health components of functioning and disability, and it complements the ICD. So therefore, ICF is a thing which complements the ICD. It helps you understand the disease better. Measures health and disability at individual and population levels. Just remember there is something called as ICD and something called as International Classification of Functioning, Disability and Health. With that, we come to the end of the chapter, Concepts of Health and Disease. The second chapter in your book, very important chapter. In the course of this, I have already told you what are the important Viva questions and what are the important notes that could be asked. Please go back to your, books, underline them right now in case you can, and at least keep something in mind. In the next class, we will start the principles of epidemiology and epidemiologic methods. This is a very, very important chapter again. This is the chapter number 3 in your book, and it's a pretty long chapter. There are 2 or 3 long chapters in your book. One is the one on communicable diseases, and the one is on epidemiology. So please remember that. Please attend in large numbers. I know it's a difficult time. Many cases are happening in Hyderabad, and I'm sure the places where you are in different parts of the country. Take care and be safe. Follow the methods of wearing a mask, unlike me. And in case you have symptoms, at the earliest, avail of a health facility. Thank you.